Hello and welcome back to lecture series 2022. Today is the 57th lecture. Yesterday, somebody asked me, sir, can you take class on fetal hydrops? I was wondering why that person is asking. The another PG sent me the actual question paper and said there was a question on fetal hydrops. It was a immune hydrops, how to manage in the subsequent pregnancy. And then there was a question on non-immune hydrops as well in another question paper. Believe me, when I was a PG, I never liked this topic, non-immune hydrops. Somehow I thought it's a very difficult topic. I kept it for the end so that you won't forget the causes and all that. That time I didn't realize it is so easy actually to remember. You have to remember just one or two aspects of it only, and then everything will come to you. Maybe I was very young and immature that time. We always thought that we have to remember things. Now I tell the students, don't remember things. I may be the first teacher who is telling that don't try to remember things. Then what we should do? How are we going to solve the problem? Try to understand the subject. Once you understand the subject, whether you like it or not, you will remember it. So let me go ahead with fetal hydrops, both immune as well as non-immune, and try to make it very simple for you so that you don't have to read it again, you don't have to remember it again, you will just write an answer, good answer in the exams. Okay, what is the definition? As the name suggests, it's an abnormal. Abnormal can be less or more. So I have written in bracket excessive collection of serous fluid in at least two places: fetal skin edema, ascites, pleural effusion, or pericardial effusion. Anywhere but two places. That's called hydrops. Or one effusion plus anasarca. Anasarca means everywhere fluid, and basically ascites also will be present. It's called hydrops fetalis. Both are almost the same. They are asking for excessive collection of serous fluid in multiple places. It is usually accompanied by a big placenta and polyhydramnios. So it's not just there is abnormal fluid within the baby in different compartments of it, but also outside the baby, but within the amniotic cavity. That is why it is called polyhydramnios. And you all know, other day I was taking class on oligohydramnios. The contributor of LICA is both fetus as well as the placenta, isn't it? The placental circulation. So these babies will have a big placenta, and that's why there will be polyhydramnios as well. So there's fluid everywhere, and the name is hydrops fetus or fetal hydrops. What are the types? There are mainly two types. One is immune fetal hydrops, IFH, which is due to alloimmunization as occurs in RH, isoimmunization, RHD, alloimmunization, what we call. Other one is non-immune, which has nothing to do with the destruction of the RBCs because of an alloimmunization. And it is called NIFH, that is non-immune hydrops fetalis or fetal hydrops, which may be due to causes such as multiple fetal anatomic and functional disorders. So this leakage of fluid could be due to an anatomical problem and due to a functional disorder. Now you all should think where all the fluid is there and from where the fluid can go to another compartment. That's all we needed to think. Instead of that, we simply try to remember a big list that is there in Williams. Let's see how to remember that in a simple way. First, let's look at immune fetal hydrops. The incidence of immune fetal hydrops has drastically come down, thankfully, due to better understanding of alloimmunization. I have taken big class on that, how to prevent it and how it is actually less because of maybe ABO incompatibility in the first place. That itself will neutralize. The natural antibodies will kill the opposite antigen from the fetus, or maybe as such the Rh negative mothers are less, there is universal adoption of antenatal anti-D, and we have also understood to give additional anti-D whenever there is sensitizing events. We are giving routine postnatal anti-D if there is a positive fetus with a negative direct Coombs test. So because of all these reasons, it has come down. The use of anti-D immunoglobulin, that's what I just now said. Improved diagnosis in case, in spite of all that, if immunization happens, we can diagnose it easily with a non-invasive methodology of MSAPSV, that is middle cerebral artery, MCAPSV rather, and peak systolic velocity. Monitoring we can do, as well as therapeutic interventions with intrauterine transfusion. Other day I was taking a case discussion on RHIS immunization case. That time I had discussed all those things. Today I will again repeat it. What is the pathophysiology? Part of the advanced stage of hemolytic disease. So when there is excessive destruction of the fetal RBCs, this will happen. It is due to the destruction of fetal red cells by RHD antibodies, which are crossing over from the mother to the fetus, and they destroy all the RBCs of the fetus. Hydrops occurs when the fetal hemoglobin deficit is at least 7 grams per dl, a deficit below the mean for gestational age. So how do you calculate the deficit? What is the target and how much it is less? Or if you want to go by the absolute value of hemoglobin, it is less than 5 grams per dl. And hematocrit is half of what is normal. It is less than 15%. It is associated with even thrombocytopenia and neutropenia. It's not just the decreased red blood cells, but even platelets are decreased and even neutropenia will be there. So what are the diagnostic steps in an immune fetal hydrops? First things first, husband's or partner's blood group and RHD type is determined once the mother is negative. If he is positive, his zygosity should be determined, because if he is homozygous, then there are more chances. If it is heterozygous, then there are less chances. All offsprings would be positive if it is homozygous. Hence, fetal RHD typing is not necessary in such a person. If it is heterozygous only, and if facilities are available and affordable, then fetal RHD typing can be determined by cell-free DNA testing on maternal plasma. This facility is nowadays available in many places. The only sticking point is the cost of it. But if the person can afford the cost, then go ahead and do it. Otherwise, you can simply take anti-D if she continues to be ICT negative. If cell-free DNA testing is not available, fetal RHD gene status may be determined by PCR if you want. If both cell-free DNA or PCR tests are not possible, then the fetus is presumed to be RHD positive. That's what I said. And you do a Coombs test. If it is negative, give antenatal anti-D. So if it is negative, you keep repeating it every 4 weeks to check if it becomes positive later in pregnancy, because as the other day I was talking, even in the first pregnancy, index pregnancy means in the pregnancy where the fetus was positive, there is a chance that the mother would be sensitized, and with the subsequent exposure, she can develop antibodies within 6 weeks to 6 months. So it is possible even in the index pregnancy for her to develop antibodies. So that is the reason why it should be repeated every 4 weeks. Once doing is not enough. If ICT is positive, then it's allo immunization, hence the risk of fetal hydrops exists. So what we are supposed to do? ICT titer is repeated monthly. As the students other day, they were answering excellently. I think the students were from IOG, that is Institute of Obstetrics and Gynecology, Chennai. They were answering very nicely, and they said that we have to do this. And we know whenever the titer is more than 1:4, it is a good possibility. 1:16 means there's a high possibility of the fetus or mother having higher number of antibodies and fetus developing problems. Critical level is 16 or 13. As I was just telling, a threshold value is 15 international units per ml if you actually estimate the antibodies. Otherwise, just the ICT titers of 16, 1:16, 1:32 is bad. 1:256 is a definite case of isoimmunization and hemolytic problem. ICT is discontinued once the critical titer is reached because there's no point in doing ICT anymore. The baby is already in danger, so there's already anemia setting in. It is better we go with the monitoring by Doppler velocimetry, that what I just now said, MCA PSV is performed after 20 weeks and repeated every 2 weeks. There is a big debate when to start it. Some people say start at 18 weeks, but I'm putting it as 20 weeks or 22 weeks because you should be doing any test at a time when you can offer some treatment. At 18 weeks, if you do, and if it is, what are you going to do? You can't do anything much. Whereas at around 20, 22 weeks, you can even think of doing an intrauterine transfusion if you like, and by 23, 24 weeks in the West, they are confident of delivering the baby as well. Even in India nowadays, most of the centers, including Manipal, we are very confident of delivering the babies at 28 weeks. So starting MCA PSV at around 20, 22 weeks makes sense. So to identify fetuses that are likely to be severely anemic, this has got a direct correlation. The fetal anemia and MCA PSV has got a direct correlation. The sensitivity is almost 100%, specificity is almost 100%. What is the management? Obviously, you have to do intrauterine transfusion, right? Whenever the MOAM is more than 1.5 for gestational age, it indicates a chordosynthesis for determining fetal hemoglobin, hematocrit, and not just diagnosis of that. You would use the same chordosynthesis for intrauterine transfusion as well as. If it shows severe anemia, then IUT is indicated. IUT may be repeated at intervals of 2 to 3 weeks. I'm answering all the questions that I asked to the students. So how often you repeat chordosynthesis or how often you do the IUT? 2 to 3 weeks intervals. That's exactly why if you start as early as 23, 24 weeks, maybe a couple of IUTs you do. Whereas if you start it late, then within 1 or 2, you would like to deliver. Believe me, it is not an easy job at all. Early delivery and exchange transfusion post-delivery is preferred by many. So they would rather deliver the babies at around 34, 36 weeks. Though it is preterm, it is better managed outside the maternal womb rather than inside the maternal womb. Of course, you have to take care of the lung maturity by giving steroids. And if it is earlier than 32 weeks, you may also think of neuroprophylaxis by giving magnesium sulfate. Cesarean for very and extremely preterm babies is obviously the mode of delivery, especially if it is less than 1,500 grams and less than 34 weeks. Now I turn my attention to the most difficult one, which I thought it was most difficult one at the time, non-immune fetal hydrops. Let's see why it was difficult. It was difficult because there are some more than 48 to 50 causes. Can I remember all those causes? No, I cannot remember all those causes, but I can easily remember category wise. I can easily remember. Yesterday I was talking to you when a long question is asked on fetal hydrops. How do you write that? You categorize the answer. What is it? How is it? What's the introduction and non-immune, immune, and how to diagnose this, and what are the reasons for that, and things like that. So with decrease in immune fetal hydrops, non-immune fetal hydrops constitutes 90% of the cases of fetal hydrops. In other words, if somebody diagnoses, a fetal medicine specialist diagnoses a fetal hydrops, it is obviously non-immune hydrops because Rh isoimmunization has decreased. And if the mother is positive, obviously, definitely it is a non-immune hydrops. And that's where you have to start thinking what is the cause of it and whether the cause can be treated. If not treated, whether at least you can salvage the baby by delivering the baby early. The prevalence of non-immune fetal hydrops ranges from 1 in 1,500 to 1 in 4,000 births. That's quite rare, thankfully. again. What's the etiology? This is the toughest part. The main reason for non-immune hydrops fetalis is transfer of fluid from vascular to interstitial spaces. And this can happen because of any or all of the following. As I told you, it is the fluid which is collected in a wrong place, somewhat like in OHSS we say. And where does the fluid come from? It should come from a vascular compartment only, right? So we have to only think of those causes which will push the vascular fluid into extravascular space or the third space. It could be due to obstruction for the lymphatic drainage in the thoracic or abdominal cavities. That's one reason. Second is increased capillary permeability. It is a no-brainer to me now. But when I was a PG, I was thinking, why should it go? I mean, these are some of the things which are so easy, but you don't think of it. You would rather remember it. Don't remember. The basic structure you have to remember. Basic problem is that the fluid going out. Why should it go out? Unless the vessels are leaking. Why should it go out? So there is increased permeability. Then we will see why there is increased permeability, whether it is damaged because of some situation like preeclampsia or anything else in the fetus. Increased central venous pressure. So porous is one thing and somebody is pushing is another thing. Like if you hold a sieve, you pour a, let's say juice, but you will stir it also. So you have to pressurize so that the juice will come down. So that's how it is. Permeability is one thing, increased central venous pressure is another. Both of them working in tandem, there will be extravascular fluid collection. Decreased osmotic pressure. See, this is a simple mechanism. If the osmotic pressure is here less, then the water will go from here to here. If it is less here, it will go from here to here. So it is just a shift of the fluid, isn't it? So let us see what are the disorders contributing to non-immune hydrops fetalis. Obviously, main chunk has to be cardiovascular because that's where the whole blood is there, whole fluid is there. And from that cardiovascular system only, the fluid has to go. 22% of the time it is cardiovascular problems. So in other words, if you have ruled out RH isoimmunization, then think of the cardiac problems in the fetus as the first cause. So after all, it's from there the fluid has to go out, isn't it? 22%. There could be structural defects in the heart, such as abstain anomaly, phallus tetralogy with absent pulmonary valve, hypoplastic left to right heart, premature closure of ductus arteriosus, AV malformation, that is vein of Galen aneurysm. Now, how to remember all these things? I'll give you a simple way of remembering all these things. You don't just remember. Over the years, you have understood there are few problems in the heart. You can look here and say all possible problems are there. Abstain anomaly, phallus tetralogy, absent pulmonary valve, hypoplastic left and right, anything and everything that is there. That is a structural defect, okay? Then the heart is not pumping properly, cardiomyopathies. It has to be either a structural problem or a functional problem. I told you that in that slide. Structural problem, think of all the possible structural problems. And functional problem, cardiomyopathy, the functioning of the heart is affected. Or without mentioning cardiomyopathy, you can simply say, what is the function of the heart? Pumping, isn't it? Either tachyarrhythmias, bradycardia, bradyarrhythmias, as may occur in heterotaxis syndrome and with endocardial cushion defect, or in maternal SLE with anti-Ro/anti-La antibodies. So every organ, remember a structural problem or a functional problem, and simply rattle out the causes. So this slide alone has got some 15 causes. But is it difficult at all? No. We have understood the basic point. That is, the fluid has to go out. From where? The organs which have got a lot of fluid, which is the main organ, cardiovascular system, right? 22%. Structural problems of the heart, functional problems of the heart. Next, Chromosomal problems. Of course, chromosomal problem and heart anomalies are hand to hand. That's what you can diagnose even as early as aneuploidy screening, isn't it? So that's where you will, there are so many soft markers which and cardiac markers are included in that. So 13%, after 22%, you come down to 13%. If you want to remember it as 11%, half of it, right? Turners, you already know the webbing of the neck and the so many other problems. Triploidies, trisomy 21, 18, 13 are notorious to have cardiac problems. You know this day in and day out. So chromosomal problem means you straight away, even if you forget Turner syndrome, simply remember trisomy 21. We all know that Down syndrome baby will have heart problems. 18, 13. These are the three. 13, bad number, 18, 16, and 21. So anyway, we know. Then comes hematological. Where should the fluid come from? Hematology only, isn't it? So hematological problems. So 11% you can see. So cardiology 22%, chromosome 11%, hematology also 11% you can see. Just remember that. Or simply 10%, 10%, you can put it like that. 10, 10, 20, whichever way you like. Hemoglobinopathies such as alpha-4 thalassemia, when there is defective RBCs, they are broken. Isn't it so simple? I don't know why I didn't understand when I was a PG. All these things. Maybe we were just trying to think. Now also you may think, why thalassemia there should be hydrops? Thalassemia means what? These are the structurally defective RBCs. They will be broken. There will be hemolysis with the slightest problems. So when there is hemolysis, that's what happens in even RH isomerization, isn't it? Lysis of the RBCs, anemia. Thalassemia means what? Anemia only. So simple, isn't it? Erythrocyte enzyme and membrane disorders. If there is membrane disorder, RBCs will be broken. So simple. Erythrocyte aplasia and dyserythropoiesis. Dyserythropoiesis means what? There is no production of RBCs. There is no production of RBCs means what? Anemia. Anemia means what? Drive away the fluid. Okay, anemia is the one that's the problem which is causing, isn't it? Ultimately, you think everything around anemia. Decreased erythrocyte production. You can simply think in the examination, I'll simply think like this and think of anemia. What are the things that can cause anemia? You can just start writing decreased erythrocyte production or erythropoiesis, breaking of the RBCs due to membrane disorders or erythrocyte enzyme problems, or thalassemias, and fetal-maternal hemorrhage finally. If everything is fine, let's RBCs are fine, there's no thalassemia, there's no nothing. Simply there is massive fetal-maternal hemorrhage and that will cause the anemia in the fetus. Ultimately, what is the keyword here? Anemia. In hemolytic disease, anemia. In hematological disorders, anemia. And in cardiac problems, it's not anemia, but decreased oxygenation. So that will again the problem, right? Then let's see, infections. What will infections do? They will also attack the RBCs probably, or the whole hematological system. 7%. So half of, let's say, chromosomal problem. Chromosomal problem is 13%. This comes to half of it, 7%. Parvovirus 19. These are the usual culprits, usual suspects. Do you want to remember this? I don't want to remember this. So just start opening your mouth and start talking. It will just fall from your mouth or lips or whatever you say. Parvovirus, syphilis, cytomegalovirus, toxoplasma, rubella, enterovirus, varicella, herpes simplex, Coxsackie virus, listeriosis, leptospirosis. Enough. You don't remember Chagas disease and Lyme disease, doesn't matter. These many viruses are more than enough. If you want, I don't know whether you can talk about coronavirus. No, it's not so far. And disorders continuing, thoracic abnormalities. Now, thorax also has got some fluids, isn't it? Pleural cavity, pericardial cavity, and everywhere there will be some fluid, 6%. Cystic adenomatoid malformation. Again, let's say what could be whatever problem happens in thorax is the problem. This is the usual problem. cystic adenomatoid malformation, pulmonary sequestration, diaphragmatic hernia. Again, think of all possible problems in the fetus, and you write to your shock and surprise, you'll be correct. Hydrochylothorax, congenital high airway obstruction sequence, mediastinal tumors, skeletal dysplasia with very, very small thorax. So all possible problems in thorax you can think of, and that will cause hydrops fetalis. Lymphatic abnormalities straight away. First slide itself I showed you. How will the fluid go out? Maybe lymphatic problems, or maybe because of increased permeability from the normal vessels and because of increased venous pressure pushing the fluid outside. So lymphatic abnormalities straight away, another 6%. So it's usually 22%, 10, 10, 10, 7, 7, 7, or 6, 6, 6, whatever you say. Cystic hygroma. Now you can see that. Systemic lymphangiectasis, pulmonary lymphangiectasis, placental, twin and cord abnormalities, placental chorioangiomas, twin-to-twin transfusion syndrome, twin reverse arterial perfusion sequence, twin anemia polycythemia sequence, cord vessel thrombosis. All of them, all these problems you know already. That twin-to-twin transfusion makes a oligopoly sequence, and babies also will be anemic there, isn't it? Kidney and urinary tract. Of course, kidney has got a lot of fluid. All the fluid is filtered through the kidney. So in other words, I'll tell you a very simple way of remembering. Whether there's a question on fetal anomalies or fetal hydrops or whatever it is, there are few organs in the body. What are the organs in the body? Brain, heart, liver, kidney, and of course thorax, if you can take lungs, and intestines. If there is problem in the body, it has to be these only. Anomalies in these only. Isn't it so simple? Kidney and urinary tract, 2%, kidney malformations, bladder outlet obstructions, congenital nephrosis, Bartter syndrome, mesoblastic nephroma, then syndromic clauses, 4%. Whole lot of syndromes. If you remember, very good. If you don't remember, just don't worry. Let me see whether I can pronounce these, some of this. Arthrogryposis multiplex congenita. I don't want to remember. Lethal multiple pterygium. Congenital lymphedema. That is okay. Myotonic dystrophy type 1, we know that. New Laxova. Listen and forget. Noonan syndrome, yes, we know. Then Strokear syndromes. You can simply say some syndromes, okay? But if you remember, fine. If you don't remember, fine. Other rare disorders. This is very interesting. Inborn errors of metabolism. That we know. Most of the problems in the fetus are due to inborn errors of metabolism. Gaucher's disease, galactosialidosis, GM1, all these difficult pronouncing, very interesting problems. If you remember, you write 1 or 2. If you don't remember, just don't bother. But remember the subheading that other rare disorders. Nobody is going to actually diagnose this. You will simply remember one thing, that is inborn errors of metabolism. And nowadays, newborns, all of them are going to be screened for inborn errors of metabolism. Finally, our most favorite cause, that is the idiopathic, 18%. So we went through the causes, different organs, most of the problems in the hematological system, cardiovascular system, and other systems also. Now, let's see how to diagnose. This is common, whether it is immune or non-immune. Abdominally, uterus is more than the period of gestation. Obviously, there will be polyhydramnios that we told. Ultrasound-wise, when 2 or more of the following is seen, that is fetal ascites, that's a must. Bowel may appear compressed. Pleural effusions, unilateral or bilateral, may compress the lung tissue. Fluid in 2 cavities, I told you. Now already ascites and pleural effusions are over. There's one more cavity, that is pericardial effusions. May be difficult to visualize sometimes unless you are a cardiologist yourself or a fetal medicine specialist. Skin edema. It's a late sign actually. After completing all the cavities, it will come down, seep into the skin, under the skin. Subcutaneous tissue thickness on chest or scalp is more than 5 millimeters. Polyhydramnios. Amniotic fluid volume is more than 25. Single vertical pocket is more than 8. Buddha sign. Remember, there's a halo around the neck because of the scalp edema, and there's big ascites, laughing Buddha type of. It's like this. That is the Buddha sign. Placenta is also big and thickened, I told you, more than 4 centimeters in the second and more than 6 centimeters in the third trimester. Multiply by 2. Second trimester multiply by 2 is 4, and third trimester multiply by 2 is 6. How do you manage? That's most important. Principles are identification of utero treatable causes. Can you treat inside the uterus when the baby is inside the uterus, especially because you are not ready to deliver the baby? Other option is delivering if continuation of pregnancy has risk of intrauterine fetal death. That's what I said. If you can deliver comfortably and you have confidence in your neonatology unit, deliver them early. Otherwise, try to take the baby to an extent. But it's always a fine balance. If you wait too much, there may be IUD. If you bring out too early, there may be neonatal death. If fetal echo and targeted anomaly scan doesn't reveal any abnormalities, then Doppler assessment of the fetal MCA PSV should be performed to diagnose moderate to severe fetal anemia of any etiology, immune or non-immune. As long as there are no major lethal anomalies in the heart or in the lungs or in the kidneys or in the other areas, if there's anemia, nothing to worry. You treat the anemia, take the baby to a level where you can confidently deliver. That's what is the meaning of it. Let it be immune or non-immune. Management is same. Management is that of anemia in the fetus. That is by intrauterine transfusion. Very clear. Attempts should be made to diagnose the cause of anemia. For example, parvovirus can be easily diagnose fetal-maternal bleeding and hemoglobinopathies. Irrespective of etiology, fetal anemia is treated with IUD. That's what I told you. I have written it also now. As in case of an immune hydrops, and an early delivery should be contemplated. Other treatments, fetal tachyarrhythmia can often be treated by maternal administration of rate controlling agents. These are some of the fetal therapies that are coming, both medical and surgical. Medical treatments are more popular, which also includes giving some of these drugs to bring down the arrhythmias. Maternal treatment with propylurothiazole or methimazole is an effective transplacental treatment of affected fetuses due to maternal Graves' disease. The prognosis is poor for fetuses with aneuploidy. Of course, we have to counsel the patients properly if the aneuploidy is seen, whether to continue with the pregnancy or not. Some of them do not want to. In non-lethal aneuploidies, early delivery is indicated so that outside the uterus, it is easier and better to treat. Other treatments, prognosis of hydropic fetuses with congenital pulmonary lesions depends upon the gestational age at the time of development of the lesion. Earlier the development, poorer the prognosis because the lungs have never expanded due to poor lung growth and function. Therapeutic options include needle aspiration of shunting is planned, if shunting is planned, placement of a pleuroamniotic shunt, or open fetal surgery. This is very, very rarely done. I don't think it is done anywhere in India. In twin gestation, if hydrops is due to twin-to-twin transfusion syndrome, treatment involves utero ablation procedures, laser ablation, which I've talked in detail in the TTTS monochorionic twins. Selective feticide is not at all an option, but anyway, sometimes you are forced to do that of a hydropic twin, can also reverse the maternal disorder, thereby allowing prolongation of the fetus, that is the one fetus. NIFH is associated with overall perinatal mortality of 50 to 98%. That's a tragedy, whatever you do. Among the live-born infants, mortality again 43%. Even if they're born, mortality is high. The risk of recurrent NIFH depends upon the underlying etiology. Therefore, every effort should be made to determine the cause. To answer the question in Ballari question paper, if it was due to RHS immunization, this time I've told you all the steps to be followed. If it is due to NIFHS, a targeted anomaly scan is the most important one. If you rule out the lethal anomalies and aneuploidies, you have a better chance. Thank you very much. I hope you can write a good long answer as well as a short note answer, as well as you can at least guide the patients what to do with such a situation. Thank you very much. I'm going to upload few classes, but not many viewers. I don't know why. You complain that you cannot get a seat here. The 100 seats are occupied within minutes. But when I post it, you are not seeing properly. Please do that. And when you do that, you actually share it with your friends, subscribe to it, and like it if possible. Thank you very, very much.